Hello, my name is Kathryn Chu, and I'm the Director for the Center for Global Surgery in the Department of Global Health at Stellenbosch University in South Africa. Today I'd like to discuss our editorial, Surgical Care at Rural District Hospitals in Low and Middle Income Countries, an essential component of universal health coverage. Surgical care has long been considered too exclusive and uneconomical to be a public health priority, despite 1/3 of the total global burden of disease being attributed to surgical conditions. 5 million people worldwide do not have access to safe and timely surgical care, the majority of whom live in low and middle income countries, including in sub-Saharan Africa. The Lancet Commission on Global Surgery has highlighted surgical care as an important component of universal health coverage, and the World Health Assembly passed a declaration stating that timely and safe, essential, and emergency surgical care were key components to universal health coverage, and that district hospitals should be the backbone of essential and emergency surgical care. In order to achieve equitable access to emergency and essential surgical care, strengthening surgical health systems, especially at the district level, required prioritization. And the case for developing essential and emergency surgical care at the rural district hospital is compelling. Healthcare provided closer to the community has been shown to have improved outcomes for patients of all types of medical conditions by reducing patient out-of-pocket expenditures and improving health-seeking behavior. In this editorial, we discuss 5 challenges and then potential solutions to providing essential and emergency surgical care at the rural district hospitals. These comments came out of a conference, the Rural Health Conference, that was held in September 2019, in which a workshop with key stakeholders of providers of essential and emergency surgical care at the rural hospital participated. The first challenge that was discussed was the lack of trained staff. In order to provide safe surgical care, there needs to be a surgical team, which consists of a surgical provider, an anesthetic provider, and theater and recovery room personnel. At some hospitals, there would only be one doctor who would have the surgical or anesthetic skills to perform the operation, and at other hospitals, the rate-limiting step was the lack of theater personnel, especially scrub or recovery room nurses. Another significant challenge was the lack of appropriate levels of skills and training for rural healthcare providers, which include doctors, nurses, and clinical associates to provide essential and emergency surgical care. Without standard training across medical schools and internship, the skills of rural South African doctors in performing surgical care is variable. Some participants reported that their skills were self-taught. Family physicians who have trained in certain surgical procedures work at many district hospitals. However, some of these facilities only have one of these specialists, and that's not enough to form a safe surgical team. Some participants described surgery as the fear of the unknown and reported feeling inadequate to perform some of these procedures. Another important challenge reported was the poor communication and lack of support from specialists, including surgeons and anesthesiologists, at the 2nd and 3rd level hospitals. Rural healthcare providers also expressed frustration trying to refer patients or obtain surgical advice on patient management over the phone. They felt there were often long delays to reaching specialists by phone, shortages of beds when they tried to refer patients at the higher level hospital, and a real lack of ambulance services. They also felt that rural doctors would be criticized if they tried to perform a surgical procedure and had a poor outcome. Even when the rural healthcare providers felt that they did have adequate training to perform certain surgical procedures, they did not perform them due to the fear of criticism. And in addition, training was limited by the lack of formalized mentorship from specialists, outreach, and in-reach opportunities. The fourth challenge was a skills and resource mismatch. At some facilities, there were enough personnel, there were trained surgical providers, anesthetic providers, recovery room nurses, and theater personnel. However, there was not the infrastructure, equipment, or appropriate medications to perform safe surgical care. For example, there were no ventilation machines, or there was a lack of specific equipment to perform the actual operation. And finally, the biggest challenge probably would be the ill-defined role of the district hospital in essential and emergency surgical care provision. Without national surgical, obstetric, and anesthesia plans that designate the role of each hospital, health districts are often left to decide for themselves which hospitals would perform surgical care, and by default, most of this is then left up to the second and third level hospitals, creating huge backlogs of cases and a shortage of personnel that can perform the operations. In summary, there are multiple challenges to providing essential and emergency surgical care at the rural district hospitals. The World Bank has described 28 cost-effective procedures that can be performed at district hospitals, and each country needs to adapt this list to its own needs. In South Africa, the National Department of Health has defined a district health package of surgical care. However, this is not enforced, so different district hospitals perform different procedures, and there is no incentive to improve or to scale up this surgical capacity. Each health district should establish a surgical task team to determine how district hospital essential and emergency surgical care will be delivered for their catchment. And this task team should include stakeholders from all the facilities, including the specialists at the second and third level hospitals, as well as the district hospital rural doctors. And the service delivery solutions might be different between health districts depending on the size, number of, and type of hospitals, as well as distances between health facilities. For example, in an urban area, the transport time from the district to the tertiary hospital may be only 30 minutes, while in a rural area it might take more than 8 hours to transfer patients. This can play into the decision of how much surgery the district hospitals will be doing. And explicit in the task team mandate in determining the role of the district hospital in essential and emergency surgical care would also depend on what the current capacity is at the district hospitals to perform care, as well as the capacity at the second and third levels. And buy-in for district hospital surgical care is critically needed by specialists who so often consider surgical care delivery by non-specialists to be second-rate. In reach, we're having rural doctors rotate at the second and third level hospitals, and outreach, the rotation of specialists at the district hospital level, can be effective in ensuring a team approach. Task sharing or co-management by healthcare providers of various cadres is also needed for quality essential and emergency surgical care. The surgeons, anesthetists, obstetricians from the second and third level hospitals can support the district hospital doctors in surgical care through remote co-management as part of a larger surgical ecosystem, rather than each hospital performing operations independently. These specialists should also be available for timely management and referral advice, and mobile health tools would greatly improve communication, help capture this data, and even used as teaching platforms. Finally, monitoring and evaluation of the quality of care of the district hospital surgical care is essential, and this can be collected through standard indicators and shared across the health platform. In conclusion, rural district hospitals should be supported as an essential component of a surgical provision. In the case of South Africa, as in many low and middle income countries, the surgical capacity thus far is not well developed at rural district hospitals. These barriers, however, can be mitigated through political prioritization, increased support from specialists at the higher level facilities, and additional training. Surgery saves lives, and rural hospitals must improve their safe surgical provision to bring us closer to health care for all. Thank you.